Good evening, everyone. Welcome to the July Newcastle Institute webinar. My name is Robin Considine and I welcome you to this night's event. In Newcastle, we're proud to continue the tradition of sharing and learning that has occurred here for thousands of years, tonight occurring in this virtual space. We pay our respects to elders past, present and future on for the Awabakal and Worimi peoples. The Newcastle Institute was formed in 2004, primarily to promote rational discussion of diverse ideas that impact on us all as we live as part of our communities. Now more than ever, we need these opportunities for rational debate. Tonight, in discussing mental health in Australia, the challenges and solutions, we acknowledge people who are living with mental illness and those with a direct experience of suicide, including those who have attempted suicide and those bereaved by suicide. We also understand in this global pandemic that you may be experiencing greater challenges with your mental health and also in access to care and support. In particular, we know that there are people in Melbourne and the rest of Victoria who are regularly join us on these webinars who may be struggling. We support you in the current difficulties, and we look forward to your participation tonight. Before we start, if someone you know needs help with mental illness, or if anything in this webinar causes you concern, please talk to your friends and family, speak to your GP. If you can access the internet, there are a number of sites you can go to, including Beyond Blue, for young people, Headspace, and particularly the eHeadspace, or ring Lifeline on 131114. We will put these links on our website tomorrow when we upload the video of this. Tonight, we have the privilege of 3 internationally and nationally renowned experts in mental health on our panel to discuss the situation in Australia, particularly focusing on the challenges and solutions. Firstly, I'd like to welcome Professor Pat McGorry to our panel. Pat is former Australian of the Year, I think in 2010, and also Executive Director of Origin, Professor of Youth Mental Health at the University of Melbourne, and Founding Director of the National Youth Mental Health Foundation, also known as Headspace. Pat is a world-leading researcher in the area of early psychosis and youth mental health, and has been directly involved in research and clinical care for the homeless people, refugees and asylum seekers. And importantly, he's a former Novocastrian.
So thanks, Robin. And I wouldn't say former. You know.
Also, Professor Frances K. Lampkin, who is Acting Pro Vice Chancellor of Research and Innovation and a mental health researcher at the University of Newcastle. Frances is an NHMRC Senior Research Fellow, Director of Translation at NHMRC, the NHMRC Centre for Research Excellence in Mental Health and Substance Abuse, and Co-Director of the Mental Health Hub of the University of Newcastle's Priority Research Centre in Brain and Mental Health. Frances leads an international team of researchers, clinicians and industry partners in the innovative development and translation of evidence-based treatments for comorbid or co-occurring mental health disorders. Our last panel member is Dr. Brendan Flynn. Brendan is Director of Medical Services at Hunter New England LHD Mental Health Services, also a conjoint senior lecturer at the University of Newcastle. His area of clinical subspecialty is the mental health of older people and mental illness co-occurring with cognitive impairment. Brendan has published on topics including medical education, ethics and clinical psychiatry. So welcome everybody.
Thank you. Thanks for having us.
Thank you, Robin.
Time is particularly pertinent in these difficult times. Firstly, we all know that mental illness is common in our community. I think 1 in 5 people or 20% of the population will experience one of the common mental illnesses like depression, anxiety or drug and alcohol problems in any 1 year. But only a small portion, I think it was estimated about 35% access treatment. with this access problem even greater in regional and rural and remote areas, and in particular age groups or vulnerable populations. I just wanted to get your views on why is access to treatment still such a challenge? And also the second part, what can be done to improve this, particularly for those vulnerable groups or areas? Pat, do you want to make some comments on that?
Yeah, thanks, Robin. Yeah, well, it's a very, very good question. You know, when you look at it like that, it's really the main health problem of young people, but it's one of the top 3 non-communicable diseases. I know we're struggling with a communicable disease at the moment. That's probably overshadowing everything. But when you look at the NCDs, mental illness is right up there with cancer and heart disease. And if you look at the economic effects of mental illness, it's twice as important, you know, as cancer, certainly. You know, the World Economic Forum showed that 10 years ago. So, and every Australian in their family has someone with mental illness. So I know I have, and you know, I don't know any family that doesn't have someone with mental illness in their family. And if you look at the New Zealand study from Dunedin that was published recently, 85% of people, not 50%, not 20%, but 85% of the people by the time they reach the age of 45 will have had a period of diagnosable mental ill health. So given those numbers, why is it so neglected in terms of, you know, inequity in the fundings in the health system, such that, you know, less than half of people with a need for care get access to care, and that's including any type of care, primary care included. And the quality of care, as we all know, having struggled within the health system for ages, the quality of care, despite everyone's best efforts, and the clinicians are very dedicated, they work hard, they do their best with a very neglected system, the quality is definitely worse. You know, and you hear patients all the time saying, when I had cancer, I had this Rolls Royce, you know, fantastic sort of service and experience. And when I had a psychotic episode, or I had a period of severe depression, you know, the treatment was like chalk and cheese, you know. So why is that? And you know, I think that the answer isn't totally clear, but it's got to be related to discrimination, stigma, and I suppose a self-defeating approach by our sector, where we keep having these public disagreements about where the emphasis should be, whether it's, you know, on prevention or treatment. We saw that in a thing in the ABC today, actually. Some colleagues basically are saying treatment doesn't work, we should put all the efforts into prevention. Incredibly fruitless debates, false dichotomies everywhere. Children's mental health versus young people's mental health, young people's mental health versus adult mental health. You know, funding envy was one tweet today. You know, fighting amongst scraps instead of uniting and fighting, you know, in a logical way, and also denial of the reality of mental illness. We've seen, you know, the National Mental Health Commission, among others, basically saying things like, you know, all we've got to do is we're all in this together. You know, we've just got to support each other. We've got to exercise, sleep better, as though that's the main response to the surge in need for mental health care in the context of a pandemic. So we're not very smart, actually, about uniting and fighting for all of these things to be addressed. So we've got to take some responsibility in the mental health field ourselves, but the public also has to take some responsibility in that they have not fought in their own self-interest for a main health problem that they themselves experience being properly addressed. You couldn't imagine the public tolerating cancer services being grossly underfunded and neglected. So why is the Australian public putting up with this?
Might add to that if I can, Robin, and I think it upsets me, as it does I'm sure the other panelists here, that there is still this stigma and this unfairness and this discrimination against mental illness and mental ill health when it does affect us all. I remember in the last couple of years, I had a really close mate who was diagnosed with breast cancer, and the community support that rallied around and proactively reached out to her was just amazing and overwhelming. We were going to a forum where there's networks there, peers who'd been through the same experience, brought her in, took her through, navigated the system for her, helped her with choices and things. And I became quite overwhelmed as a person walking beside her, thinking, this is what we need when someone experiences a mental health problem, not to be shut in their house or too frightened to admit it, or too frightened to go to work, or too frightened to go, or worried about seeking help, this is the time when we need to connect more to people who have walked that path, to our health professionals and to our wider community, and it's just not happening. Another example, just recently, I was watching an item on the news, and there was a big announcement of a big breakthrough in a new cancer drug, a new chemotherapy that was precision targeted to the exact type of tumour that a person was diagnosed with. And the very, people were lauded for going and seeking this treatment and taking this chemotherapy. And the very next item had a headline: "Pill Popping Nation, Australians taking too many antidepressant medications," relative to what I don't know, someone thought they should be. And so, antidepressants are one of the most important evidence-based treatments for depression. So just in the contrast in the way our treatments are being talked about for mental health, mental ill health, and the way in which the community, including, we all rally around people when they have other sorts of communicable and non-communicable diseases versus mental health, I think really speaks to these issues that we're all talking about here tonight.
Brendan, you're providing clinical care to people. You must see delayed access as a real issue for the people.
Yeah, thanks, Robin. Yeah, look, I think that it's sort of. I would add, so I agree that there's access issues that are related sometimes to resourcing, sometimes to stigma. I think that one of the things that can happen is significant delays before people ask for help or require to lean on someone else to ask for help on their behalf. And I think that's where it gets less able to be equated with physical health paradigms. And I'll try an example here. I don't know if this is going to be very convincing or not, but if I develop a kidney condition, I'm very unlikely, even as a medically trained doctor, to know that much about the ins and outs of that condition and the symptoms and the nature of it. But if someone has a sense, or someone cares for someone else who has a sense that this person's thoughts or beliefs or mood or behaviour are somehow of concern, I wonder if our general mental health literacy and understanding is limited, because all of us have had the experience of having mood variation, thoughts that we might not share with others, etc. So it becomes a lot harder for, I think, the person who's never had anything to do with services to work out where on the spectrum is this between psychological distress, and we're going to see heaps of that, and we are seeing heaps of that with the pandemic, and the, if you like, more discernible or more reliably described and more severe psychiatric syndromes, which is really where, and I think Pat's touched on this, but that's where the funding goes towards treating the more, if you like, discernible or severe and risky syndromes. What can happen with that sort of model is that the rest of the population who experience distress that may not, score a Guernsey for a diagnosis of a psychological disorder don't necessarily know where to go. It doesn't seem to necessarily come under a mental illness, but I like Pat's term of mental ill health, because something's not right and we need to be working on ways to find people to get help along that spectrum.
It's great what Brendan just said, Robin, because I saw a girl last night actually that one of my colleagues said, look, can you please see this young woman who's one of my students at university actually, and I knew that if she went through the usual channels, whether it's the waiting list of Headspace or the revolving, rotating blades of a public mental health service triage system, which basically keeps people out, not in Victoria anyway. That's why we've got a Royal Commission. But anyway, she came along, and she'd actually, despite Headspace being there, she'd had depression since year 8, basically. She's 22 now as a tertiary student. She had actually sought help, but she'd had one session at Headspace but didn't follow up, because she had to get a mental health plan and couldn't be bothered basically, or there was too much trouble, and when she was really depressed, and so she never got followed up. This was about 3 or 4 years ago. She'd had a couple of assessments with school counsellors, but no real follow-up with expert care. But this girl had been depressed, probably about maybe 7 or 8 episodes of serious depression with self-harm and suicidal behaviour on occasions. Could have been dead, by now. And this is like years down the track, you know. And as Brendan said, that's normal, you know. I mean, even if you've got a severe disorder like bipolar disorder, it's like a 10-year delay before you get evidence-based treatment. Psychosis, early psychosis programs which we've developed to try to reduce those delays. Most people don't have access to them. So the DUP, the duration of untreated psychosis, on average is about a year. Imagine if you had, you know, cancer for a year and you didn't actually seek help. And so that's one thing, that the ability to seek help, and it's a hard thing to do anyway. And then when you get into the system, there's all sorts of devices to stop you getting the help, you know, especially into the more specialized form of the system. And like Brendan says, you've got to get a barcode, you know, from some kind of diagnosis before, and even then you've got to have a few extra things like, you know, risk and you know, acuity or aggression to really nail it, you know, in terms of getting access to more specialized care in the public system. Private system depends on where you live and how much money you got, basically, because, you know, private psychiatrists charge large co-payments, and they live in leafy suburbs, and they don't live where I live in the western suburbs of Melbourne here, where, you know, there's probably about 6 psychiatrists and there's probably about 300 or 400 in the, you know, in the equivalent suburb on the other side. So I think there's all sorts of reasons why we're getting a raw deal, and it's complex, but we understand what the variables are, but we haven't been effective and like Francis said, I mean, you know, probably on that story that you mentioned on the news, there were a couple of psychiatrists saying, you know, the drugs don't work, you know, or anti-psychiatrists saying that, you know, so just, you know, that self-defeating element is very significant in the mental health sector.
Francis?
I would also just add that that, you know, when you add things like alcohol use problems or substance use problems into the mix, and they're also just as common, third most common mental health disorder in Australia, then that makes treatment access even more difficult, because you bring in another system which people then have to try to navigate between to work out what's the most pressing problem, or what's the original problem, and what's going to occur first and second in treatment. And certainly the work we have been trying to do has demonstrated that it actually doesn't really matter if a person's presenting in distress, that you can actually do some work with them to relieve that distress, at least in the short term, if not in the longer term, by doing some very you know, basic and good clinical things. And then again, with access to psychiatrists and to psychologists and treatment services more broadly, again, we're going to find that even more difficult once you move out of those major metropolitan areas. And, you know, I think there's not enough mental health professionals to meet the demand for services worldwide, let alone across our country.
There's been significant reforms over the last, well, quite a few decades. I'm probably showing my age now, but certainly decades that I've been around, which have made things better, I'm assuming, for consumers. So Headspace is one example, which is improved access for young people, for particularly around early intervention for mental health. I mean, the provision of a GP mental health plan, which people can access through a GP, is another significant policy reform. And there's been a range of others. Yet the challenges still remain. In terms of a policy sense, what are the barriers still for improving quality and access?
Could I kick off with that? Yeah, thanks, Brendan and Francis. I think you're right. I mean, Greg Hunt always says to me, why can't you be more positive? And well, I am pretty positive, because we've been very solution focused, and we have actually tried to formulate solutions based on evidence, and also to create evidence along the way as we're reforming. And the federal government, to its credit, and it's both sides of politics, including Greg, you know, have actually done some really good things. You know, they've actually brought in allied health into the mix, you know, alongside doctors in the primary care, which is fabulous. You know, no other country's really done that in that degree. So the knockers of better access shouldn't knock it, because it's actually a really good thing. Not perfect, but it's better than what was there before. Better than Canada, which doesn't have that at all. So, and partly because of that, we were able to formulate Headspace, which allows those people to be in the one place, you know, along with other funding streams as well. So you can build these things, and the federal government's been open to that, and I think it needs to do a lot more. Of course, it's just kind of now starting to say, well, hang on a second, how much further do we go? That means we've got to spend more money, really. So, and it's got they spent 22 billion a year on the NDIS for 400,000 people, and we're spending 9 or 10 billion a year on 4 million people plus, with mental illness. So there's a huge need for more money, absolutely huge need. Federal government's got all the money, state governments less so. But the state government's really the ones that need to be criticised, because and our Victorian government has copped it sweet. Basically, they said the system's broken. We've actually allowed it to fall apart. It's gone from covering, it's supposed to cover 3% of the population with serious mental illness, and it's covering 1%. And we've seen that system absolutely fall apart under, over the last 15 years or so. And we've had people apologising, pretending it wasn't happening, and telling us that, gaslighting us and saying, it's not really true that the system's falling apart. Well, the Premier of Victoria says it is, and he set up a Royal Commission. So state governments have taken steps back. And what did they do? They closed the old mental hospitals and cashed them in. And I trained in one of those in Newcastle. And they were due. They'd passed their use-by date. They definitely needed to be replaced with a new model. But the new model they replaced it with was jerry-built, poorly thought through, and incredibly poorly funded. So the system then had to retreat on itself and back into the EDs and the hospital system, and failed to really provide the level of community mental health care that was needed if you're going to cash in all those beds. If you're going to get all of those beds, and you don't provide the really strong, dynamic and growing community platform to replace those beds, then look what happens. It all implodes on itself. And that's happened in every state in Australia to some extent. And that's why you've got that access block too. And the bar is so high for getting into that state-funded system. So state governments need to take a really good look at themselves. But how do you actually solve that problem? You need significant funding in that mid-zone, which is going to need federal and state funding.
Brendan, that must place you in your role under significant strain. You provide clinical care in a state-funded health system. And I don't think Newcastle is any different from what's happening in Victoria, but can you talk about some of those challenges?
Yeah, look, I guess I would want to start by recognising that there is enormous need and finite resources from my perspective. And I guess part of our role is to advocate on that larger state and national scale. But I guess in practice, the dilemma I've got is an enormous denominator. There's enormous community need, and it's legitimate. And like every other resource, we are in a situation where we need to choose who we best use it for. I'm very fortunate to work with a very dedicated and motivated bunch of people in Newcastle and Hunter, New England, who care very much for the community and work very hard. But I guess one of the things I reflect on is the expectations for acute front door psychiatric services. So for better or worse, and I think arguably for better, many elements of human distress are, if you like, how would I say? I would say sort of categorised often under this idea that there's an issue. It's not physical. This person's distressed. I need to seek some help for my mental health. What the issue we've got is that people who don't have acute psychiatric syndromes but definitely need professional help, I guess presenting for assistance in a service that's set up, as Pat said, to manage that 3% of people with serious psychiatric illness. And I think what we have to continue to try and do is that if we do say to somebody, I'm sorry, I can't help you tonight with this issue, that we don't convey to that person that the problem isn't real or unimportant, or that we don't know the best direction to send that person in. And so we see a lot of people who's have really legitimate problems, but often are not going to necessarily be well served by the place that, emergency services, the community, if you like, sort of conditioned to bring into an acute psychiatric service. So it is a challenge. It is a big challenge. I like the idea of always advocating for more resources. I guess from my perspective, we have to be realistic about what our specialist mental health service can do, and make sure we're marshalling general practice, psychology, counselling services, relationships advisors, financial people, bereavement counsellors, to help people with the many and varied real psychological distress that can sometimes be, lumped together as an undifferentiated thing that definitely needs the assistance of a specialised mental health service. And I really worry that people may feel that they've been told they don't have a problem if, for example, we're not going to take them on as case managed or admit, and that's not true. I'd be interested to hear what Francis and Pat think about that, because it is a difficult road to walk.
Yeah, Francis.
I think it is it's very difficult. And as you were talking, I was thinking, gee, it's the navigation through that's the real critical issue facing, the person. So it's harder. We've talked about how it's tricky to know when the right time is to receive help. But then when you do receive help, there are lots and lots of different ways or points of entry to try to access mental health support. And often you're probably going to where, you're most familiar going, and that's why the GP schemes are really important. But often it is emergency departments where that backup and support and triaging system that's in place doesn't really speak to the need to, for the ongoing support or the stress mitigation that we might need to support someone through that mental health crisis. And I think, if that's someone's first contact with mental health support, then that can be quite off-putting as well, particularly if they're discharged, as they're quite likely to be, and then can, as you say, think, well, okay, it's not severe enough to warrant treatment, or I've had a bad experience, so I'm not going back. That's a big issue. Yep. And I think, again, I think back to what happens in the cancer space, and they had this idea of the McGrath Foundation fundraise for breast cancer nurses who actually act as those service and care navigators to walk alongside families at the point at which they come into, or they begin their breast cancer journey. And I feel like that's almost what we need here, because I don't think it should be left up to the individual or the family to try to work out which part in the system they need to access. I think that's probably, it would be a great thing if our system could come together and provide that navigation service for the person, so that when they are in distress, they're not also having to try to second guess and work out how to get help.
Probably even more important, given the complexity of the system at the moment, with the specialist state services, the primary care GP, psychologists, and then a whole range of support services who are providing more social support roles. And it is very difficult for people to work out what's needed when, including people within those services.
And if there's been a delay, then people feel more and more desperate, and that just adds another layer to that experience as well.
Well, I think what I'd like to comment on what Brendan was asking or suggesting as well, because, I mean, I was trained in Newcastle by the most amazing person, Beverly Raphael, who sadly died a couple of years ago. She was the professor in Newcastle when I started training in psychiatry, and her view of psychiatry, which is the one that I've kind of embraced, is a very holistic one. It's not this kind of narrow, serious mental illness is the only thing we deal with here, and psychiatrist's role is just to prescribe medication. She was a grief and bereavement and trauma expert, and so that our whole thinking and the way we were trained was a very broad one. We're not just mini neurologists. We're actually, this is the beautiful thing about psychiatry as a medical sort of specialty. You are trained in a very broad way. So so all the things Brendan was talking about are the business of psychiatry. Actually, they're not the business of just peer workers alone. Peer workers are a very important part of our services now, but you've got a role to actually play a broad role in this space. And so those people that Brendan's talking about that aren't for the pointy end, in life-threatening situations or acute psychotic episodes, let's say, and manic episodes especially, I think is something that has to be managed in that very acute situation quite often. But but the missing middle, the people who you know, aren't going to be helped by, you know, just 10 sessions of better access and a prescription of an antidepressant from a GP. You know, they've got broader needs. They've got psychotherapeutic needs. They've got social needs. So this is where this idea of the one-stop shop or the adult mental health hub comes in. And this is what community mental health centres should have been, but they've narrowed down to something very narrow. So we've managed to get Greg Hunt and the federal government to commit to funding this model, and it's out for consultation as of a couple of days ago. It needs a fair bit of whipping into shape, if I can put it that way. It's still not exactly what is needed for the missing middle, but if these things could be built, and maybe they can have state and federal funding and different funding streams and different professionals of a whole range of types, all the ones that you've been mentioning, in the one place. And they can be a focal point. They can all be connected in a kind of a virtual network too now, but you've got to have a focal point and a physical presence in the community so people know where they can go in a trusted way, a safe way, when they're not in an acute phase, as Brenda says. Or and the GPs and the primary care people have got to have someone to send people who are, when they're out of their depth, and you need a multidisciplinary team to manage. So it's not exactly rocket science, this idea, but it's hard to get it funded. And then people start talking, the federal people start talking, oh, well, all we've got to do is just have protocols and kind of coordination agreements between all these different wonderful professionals that apparently exist out there. That's what they tried to say to us when we set up Headspace. They said, you know, we're not going to fund a service. The Commonwealth doesn't do that. We'll just fund, you know, a series of protocols, ways of coordinating things. And we said, no, sorry, no, that doesn't work. You've got to actually have a physical platform of care. And that's why Headspace has flourished, because every community, when they see that, I want one of those. So we've got to do that for adult psychiatry too. And it can be a much more substantial thing because it's got more funding attached to it.
I agree about the value and the richness of at least, and I can only really speak for the profession of psychiatry, and I guess what we've seen is that what should be in the public sector as well as the private sector, a really genuine holistic care episode for the patient or you know, relationship over time. As the number of presentations increase, as the acuity increases, the whole thing can tend to skew towards, I think, a emergency response, which in a weird way mirrors the psyche of the person who's presenting in distress, and therefore is not particularly helpful either. So it's a risk, isn't it, that richness is lost?
Yeah, well, you get put into positions you don't want to be in. Like, you know, one of the first papers I ever wrote was showing the level of PTSD that patients experience when they get secluded or sedated, and you know, in the old mental hospitals, especially when they're first episode patients, and so, you know, you get placed in the situation of doing things which you shouldn't be asked to do, and it makes you feel very bad as a clinician actually doing that, and then the consumers and the consumer movement as well loses trust in us, and that's one of the core sources of division, because of that sort of thing happening way too often, but it's not our fault, you know, necessarily. I don't think.
We probably have to remember that some of the challenges that are faced here are not only affecting the patient, but families as well, who want to support their loved one, but are finding it challenging, and it's impacting on their lives as well as that of the person with the mental illness.
Yeah, well, that's why the hospital in the home, we just got money from the Victorian government to set up a hospital in the home model, which was what the old CAT teams, the crisis teams, used to do actually way back, you know, but in a much better way was the hospital home funding. So then you can keep more people out of those acute situations in their own home in a safe way, and support the relatives, a bit like what Brendan was alluding to. So you're ahead of the game a little bit more than you are when you're just sitting at the bottom of the cliff, you know? Sorry, I'm talking too much. I'll shut up now.
Francis, you've contributed a lot in terms of the knowledge around online treatment options as well, which can contribute to this space as well, and have been shown, I think, to be highly acceptable and effective in some situations. Do you want to just talk about that contribution?
I would absolutely love to, and settle in everybody, because I'm going to talk about this for the rest of the
Oh, I've got the mute button here, Frances. So.
Yeah, it's muting you. It's not muting me. But, I'm actually quite passionate about this, and I think COVID has thrown many things at us all. But one of the big investments that has happened is in our telehealth and telemental health systems and services, and I think this is the sort of I guess reform or accidental reform that I've been waiting for, and that many of us who work in the field have been waiting for. And I really hope that funding continues and the opportunities that this can create are realised. Because yes, indeed, although it doesn't replace the work of a clinician, there are some things that we can do in a virtual space, much like we would do working through a course online. We've done learning online as part of COVID as well. And certainly there are aspects of at least what we do psychologically in a psychotherapeutic sense that we can actually teach people to do for themselves. And in fact, that's what we do, or we hope to do when we do real live therapy face-to-face, is that we try to create a safe space for somebody to explore the things they need to explore, and then help them learn skills or mobilize their own skills that they need to then go out and use in their lives to help address the challenges that they might face. And so people don't always need a psychologist to teach you that. You need just a structured, safe environment and a program to help you do that in some cases. And so particularly for that mild to moderate end of the spectrum, things like online automated programs and evidence-based apps can certainly really go a long way to help people, who are distressed and who are experiencing things like depression and anxiety, and even now some evidence for psychotic-like symptoms and alcohol and other drug use, to actually help cope and deal with and recover from those sorts of issues. And certainly when you wrap those digital services around a health service or a mental health service, using either telehealth, so talking with people like we might be doing now, in real time, instead of sitting face to face, or integrating people within a service, that those kinds of models actually show a lot of promise, can actually help reduce wait list times coming into some services, and also can help support families and also people at the other end of their treatment episode and journey, by helping them stay well or prevent relapse at the other end. So I think there's huge potential and a lot of evidence to suggest that it is a really effective tool. Maybe, in some cases on its own, but certainly integrated as a bit of a wrap around the systems that we have in place.
I'm going to try and merge the next couple of questions because it's remarkable how quickly this is going, but they're sort of around the factors that are associated with mental illness and also suicide. We know that there's a genetic and a biological component, but we also know that things such as unemployment, childhood trauma, and a whole range of factors such as that, but particularly the economic and social ones, will impact on the mental health of an individual and indeed the family. We've seen a very strong focus on economic rationalism over the last multiple decades. And so I guess I wonder whether we can ever expect major improvement in mental illness in our community unless there's a recognition that the economic and social factors are contributing to the concerns around mental health. So that's one part of the question. I might merge the other one in a minute.
Yeah. Well, I mean, I think that's the explanation for why the mental health of young people is getting worse, and why we're having to build headspaces. And I mean, we've had to anyway because it was already the main health problem, but it is getting worse, the data that we have, and particularly in the US, it's getting rapidly worse, So I think those social and economic forces are really powerful, and the modelling that our friend Ian Hickey's done in Sydney around the suicide risk in young people, it's all driven by economic and vocational and social sort of forces, Obviously, with the pandemic, the isolation and all the other sort of things are affecting people in a temporary way, but the things that's really going to drive demand and the need for care in the next few months and few years is this economic collapse. But I think more subtly, as you said, goes right back to Margaret Thatcher and Ronald Reagan back in the 80s, actually, in my opinion, where they've gradually, it's the price of everything and the value of nothing. That the society's definitely gone down that track, hollowed out the public service, hollowed out government. The best form of government is that would fit into a bath. I think Ronald Reagan said at some point. You know, the smaller the better. So that's weakened trust. It's weakened capacity. Everything gets contracted out to KPMG these days. Even the stuff that we do in mental health research, they don't trust us to do it. They give it to these private firms who then grab a few people like us and put them together in teams. I mean, it's debased, you know, the way the whole society has gone in this respect. I bet you're sorry I asked this question, but those are the drivers. And then our friends in population mental health, like Helen Christensen and people like that, will say, well, you guys in the clinical services are missing the point. It's all about that. You shouldn't worry about, you know, services. You've actually got to focus on prevention. And of course, that's true. You know, we definitely have to do that, but we also have to provide safety nets for people. And you don't see the false dichotomies like that appearing in cancer and heart disease. So, but we've definitely got to recognize that. But there is a political element, obviously, to this. You know, if you're serious about tackling the preventive side of things, you've got to face, you know, what really are the causes. And we've got to be able to, through research, prove that these are the causes, not just have opinions like I've just been saying, but be able to prove it.
I mean, Brendan, you must see many patients that come in and you think, there's only so much I can do given their economic or social circumstances unless that's addressed.
I do. I think we are going to see more as this plays out. And it's one of the sort of reasons why the advocacy is so important, because we're sort of, when we're thinking about someone's situation, we're sort of very used to dividing things up, I guess, into things that we can change and that might you know, rapidly change, and things that are the slower background things that don't change. But if you think about it, political action can look at issues to do with poverty and homelessness and employment. And so they shouldn't necessarily, like this sort of idea that they're static factors for an individual. I guess the response to that needs to be thinking about what are we doing and how are we advocating for people to improve those factors. I think it's unarguable that they are major issues. And I would echo what Pat said, that we've got to do both prevention and treatment. And you do meet people who will make, as Pat's mentioned, the argument that we've just got to really just put all of the resources into prevention. And I'm not sure you meet people saying the opposite, but you certainly encounter, I guess, paradigms where it's all about treatment and we've got to get something in the middle. Yeah.
Well, I suppose, you know, it's fair. They could say, look, we're spending nearly all the money on treatment and nothing on prevention. So I can see their point. But I mean, it's particularly bad in the suicide prevention world, you know, because they try to say, you know, it's the upstream factors that really we should that are important on. But many of those upstream factors are very difficult to change. So what do you do in the meantime? Just let people remain seriously distressed people seeking help? Do you turn them away? I mean, they haven't thought through the logic of their position, the suicide prevention people, that you've got to do both, you know, and they always minimize the mental illness or mental health part of it. That if you think about it, psychological autopsy studies show that 90% plus of people who actually die from suicide are intensely psychologically distressed at the point that they do it. So there's an opportunity to save them at that point. There may be other opportunities upstream to save them if you can sort of fix the economy and stop child abuse and all those other sort of things. But and I'm saying you should do both. But we in our field we have people minimising the importance and the value of clinical services, and they've done it today on the ABC. So I'm particularly agitated about that.
Yeah. And I guess we haven't seen people with lung cancer or heart disease from smoking turned away from treatment.
No.
That we provide both prevention and treatment services.
Although Francis might like to comment on that bit with alcohol. My brother died of alcoholism. I'll just share that with everybody. At the age of 37, and it was denied a liver transplant, which would have saved his life just because of the nature of his liver failure.
And I wish that was the first time I'd heard an example like that. And that comes back to the stigma with which these various conditions are held and still held, and even suicide and suicide attempts when people present to emergency departments are viewed not from the perspective always. I mean, it varies, but there are people who don't view that as a person in distress who's communicating a need for help in the only way they know how. and they can be managed in a range of different ways. I don't think you'd see that if someone came in distress with a broken leg, for example. I know that's a very simplified example. And I think, if we go back to cancer again, those screening and prevention activities are used to actually then identify people who do then need more intensive intervention. So even in that paradigm, you've got a cohesive way in which the prevention and the public health approaches are not only funded, but also and the screening approaches then feed into a cohesive system of care that's designed to intervene at the level of distress or disorder that you're presenting with.
You've all mentioned the impact of the pandemic on the mental health of people and their expectation that things are going to get worse. Are you seeing those challenges already in the people that you're seeing in your services? And how do you think that this is going to progress over time?
Brendan, do you?
Yeah, very interestingly, during the I guess the lockdown months in New South Wales, at least, so particularly April and May, we saw a decrease in, and this is, I guess, very much a biased front-end emergency psychiatry perspective with this part of my service hat on, but we saw New South Wales wide a decrease in presentations, a decrease in people presenting with self-harm or suicidal ideation, and that's actually gone back to baseline now. That obviously doesn't mean that those things were not happening, but there are good reasons why people might choose to stay away from a hospital in the middle of a pandemic. But I guess what I'm expecting to see is, and again, we need the data, and this is just my opinion, but I think we've got the the viral pandemic, we've got the economic fallout, and subsequent to that, I think we're going to have a really significant social fallout, and therefore a mental health wave, if you like, that needs to be a curve that needs to be flattened. I think there's a parallel here, Robin, in the sense that the curve where it's been successfully flattened, and touch wood, that's New South Wales today, despite the excellent work of nurses and doctors and the investment in the health system, the actual intervention was achieved by the community itself. And I'm hoping that we can sort of raise awareness that by being connected to each other and looking out for our neighbours and our friends and our family, that we're not going to be relying on the mental health system for the end results, but we can intervene a lot earlier, and the answer is in the community. Now, that may be naive and it might be optimistic, but I'm really worried. And the other thing is, I think we're going to have a lot more work in differentiating what the best place for someone's psychological distress is, trying really hard to have that no wrong door approach, which is it's a very important principle. It can be hard to do, though.
Yeah, well, I mean, that's been the hope of the National Mental Health Commission so far, that they've been trying to say, if we have more Lifeline and we have more Beyond Blue crisis lines, and everyone is supportive of each other, then that's the main thing we need to worry about. And that's partly true, as Brendan's sort of saying, because most people in a crisis or a disaster, and even in a recession, will actually be okay. The majority of people will be, but there will still be, and we model this in a very similar way to Ian Hickey, about 30% increase in need for care is what we're expecting. That's not everybody. Obviously, the other 70% are not increasing, right? So there isn't. It's not. Everyone's clear that most of what we're feeling is sort of, I suppose, unease, dis-ease. We're stressed, we're anxious, we're not sleeping properly, but we're going to be okay. We don't need to. And self-help and support will work for most people. So that's the upside. But it's just head in the sand stuff to deny that if you look at the data from every other recession, every other disaster, there is a surge of increased incidents coming from new cases and people who have never been unwell, and relapsing people who have existing conditions. I've actually seen that already, that happening, and we've got data from our Headspaces showing the surge is starting. And if we ever collected proper records in the mental health system in real time, then we would be able to monitor it like they do with the cases in COVID too. So I think Brennan's right. It's something to be very worried about. And the question is, will the governments treat the lives of people with mental ill health with the same value that they treat the lives of people infected with COVID? I mean, they've turned the country upside down, spent tens of billions of dollars to save lives. And it's many lives, like it's thousands of lives, maybe tens of thousands of lives they're saving by doing that. But in the same time as we've lost 100 people from COVID, 4 months, we've lost 1,000 people from suicide. I mean, we don't know that in real time, but we know from last year and the year before that in a 4-month period, it's about 1,000 people. So it's 10 times as many people have died. And you look at the kind of seriousness and extent to which the government is taking those deaths. They're still Australians, they're still people. I just think that is just not acceptable. And the next, and what we can prevent is the excess in deaths that are coming down the pipe if we actually act now. But I don't get the sense that we are going to act in that urgent way. We're probably going to put more money into Lifeline and Beyond Blue and maybe a few tweaks here and there. But what we should be doing is building up these kind of adult hubs and resources and trying to assemble workforces to respond to what we can pretty accurately predict is going to happen in the coming months.
There have been some questions that have come up about what people can do to support their own mental health or the mental health of someone in their family.
Yeah.
I guess I would appreciate your views on what you're doing to look after your mental health, particularly in this time of the pandemic, and some tips that may be applicable to other people. Frances, do you want to start?
It's a really good question because I'm not sure about Brendan and Pat, but often it can be for me a bit of a do as I say and not as I do. But I've actually found 2020 to be very challenging, and the extra mental loads that I'm carrying around with, my husband working from home, my kids studying from home, and that constant state of of ambiguity and uncertainty, and it's almost like a threat environment that's been going on. And so all the pivoting and the changing things that you kind of have to keep in your head and to just really is over and above what our usual mental load is. And so I've been trying to do things like actually again connect with my family a bit more. So we all had to be in the same house with one another for a while, and unfortunately Pat's about to go into a similar quarantine or lockdown type status again, but just take a bit of time to spend and connect with people as people and friends and try to enjoy their company. I do a bit of I walk a little bit, I read and I watch movies. I was probably actually built for lockdown because I love just hunkering down and shutting out the world, but just finding things that actually don't sap your energy, it'll actually give you a little bit more in your reserve tank. I think that'll be different for everybody, but certainly the key things to me have been connecting with others and not dropping out of circulation like I'm prone to do if I'm getting a bit stressed and overrun, and then making sure that in every day I'm just doing a little bit of something that's just for me, that's not for anybody else, that actually is my building up time. And trying to reduce the alcohol, really, because that was starting to creep up there a little bit in the height of COVID, and that actually was not helping me sleep or cope very well either.
Brendan, what have you been doing to manage your mental health?
Look, I would agree with Frances. I think it's been a stressful year, and I guess the things that I've been doing, they're very similar. So I've been, particularly during the lockdown, I went walking with my son every morning before his school and my work, which is something we should be doing all the year. Mm-hmm. And weirdly, we've actually sort of stopped that now, which is bad. Yeah. We need to keep that going. Audiobooks. So when I'm walking by myself, I've had the companion of fellow part-time Novocastrian Helen Garner while I've been walking up and down Merewether Beach in the headphones, and that's been really good. And also, I'm from a big family. We're using Zoom to keep in touch, and also with a group of old mates, and that's been really great. And so it doesn't sound like a big thing, but I found that very helpful.
Yeah, look, I agree with everything that Francis and Brendan have said, and I suppose I found it very difficult as well, like Francis. And I'm a person, I'm a people person. I like to be with people. I don't like to talk to people on Zoom all the time. I'm sorry, love talking to you tonight, but it's not the same. Not the same, and so I struggled a bit, and also. In my world before COVID, every day was different. It was a completely variable from day to day what I'd be doing. Now it's pretty much all the same. So I found it very difficult. So what I did was, I tried to think what are my normal coping mechanisms, a bit like what Francis said. So exercise is one. So I basically I couldn't go to the gym. I couldn't go surfing because you have to drive in Melbourne to get to the beach. And so I just started running again, and I rode my bike every day for an hour at lunchtime. And I tried to stay fit. That really helped me physically. And since the lockdown finished and I was able to go to the gym again, I've been fitter than I've been for about a year. So it felt really good until tonight when we go back into lockdown. So so that's going to be hard, for me. So try not to drink too much, like Francis said. It's a temporary solution, but then it gets
and it's accessible. So I understand why people,
So I went to the supermarket when the lockdown started the first time, and and it was sort of reasonably crowded. Then I went to Dan Murphy's afterwards, and it was like Burke Street. It's just unbelievable. You couldn't get in the door. So it is a risk. I think alcohol is an easy coping mechanism, and it's got its place. Don't get me wrong. Definitely not a wowser here, but you just got to be careful, like Francis said, and so those sort of things, But I think also try to be hopeful, like our poor old premier down here, he's copping it, but he's actually done a wonderful job, and a couple of other people have let him down, probably somewhere in there, but basically supporting the leadership and having trust and hope for the future. This is not the worst thing that's happened. I mean, world wars have happened, In most countries in the world, you've got corrupt, dysfunctional governments, and people are asylum seekers. Look at the way we're treating them. They've been locked up in a hotel for 7 years. I mean, our lives are stressful now, but we've got hope. We've got hope, and we've got coping skills, and we've got friends and family, like Brendan and Francis said. So we're so lucky, really, when you look at it, the way things could be. So just trying to look at it in a different way is probably a good way to think.
I'm sure Daniel Andrews isn't listening, but one of our audience has actually said, what advice would you give to Daniel Andrews about coping with his mental health at the moment, which must be under incredible pressure?
Yeah. Well, I tweeted at him today just to support him for that reason, because I think that he's the best leader we've got at state level in Australia by a mile, and he's done really good things in Victoria. He's tackled the mental health crisis and the system. So people like him don't come along very often. So you definitely want to make sure that they're valued and supported.
We're fast running out of time. I just wonder if we could have some last take-home messages, perhaps focused on solutions for mental health at a policy system level. Brendan, do you want to start off?
Thanks. Look, I would probably try and summarise it that there's the role for advocacy and I guess trying to make sure that we are balancing prevention and treatment and really trying hard to make sure that should a formal mental health service not feel equipped to assist or best able to, that the person feels heard and valued, and that the interaction itself is of therapeutic value. Often the conversations that we may have many times during a day are of enormous sort of memory and significance to people, and just realising how important that is. So,
Francis, take-home messages?
Yes, I know we've been fairly critical or judgmental of the current state of our health and mental health system at the moment, but I don't want to take away from that, because they're very real and important issues that we've raised and discussed tonight. But I don't want people to feel like they shouldn't seek help or that there's not help available. There is help available. There's good help available, and there are good people in the system ready and prepared to help people. And so please still seek help when you're not coping and when you're not feeling that things are quite right. And that might be as a starting point with friends and family, might be through your GP, and it might be through other ends. But despite the problems and the challenges our system has, it's our system and it's there to help us. And we need to really make sure that we use it and also advocate strongly for a better deal, because we do deserve better than what we're getting at the moment.
Yeah, I think what Frances said is very important. I certainly wouldn't want to discourage people, and I suppose I'm trying to encourage people to fight for their rights really here. And we have set up an organisation called Australians for Mental Health, which you can Google, you can join, and we need like a mass movement in Australia to get where we need to go. But look, we're better off than Zimbabwe, we're better off than Papua New Guinea, so we're doing okay in some ways. Australia is the innovative capital of the world in terms of mental health innovation. And what I've always tried to do with government is give them solutions. Don't just whinge, but give them a solution. And they respond to that. I mean, Greg Hunt has, state and federal governments have definitely responded to that way of thinking. If you just go and complain and shoot your colleagues in the back, and be a whinger and a negative force, then you're not going to get anywhere. But we can do that. And Frances and I have been working together for quite a few years now, trying to bring the field together through the Society of Mental Health Research and other structures. And we've had a fair bit of success there, haven't we, Frances, in terms of getting people to think about the big picture and beyond their own sort of, petty little ambitions, really, and to think about what they're there for, to help the people, and the people, can count on us, really. We will definitely we will do our best.
Absolutely, we will.
On behalf of the members of the Newcastle Institute and also those that have been viewing it on Facebook tonight, I'd like to thank Frances, Brendan and Pat for giving up their time in extraordinarily challenging times to contribute to this webinar tonight for the Newcastle Institute. It's been greatly appreciated. We've had comments along the way how much it's appreciated. And I know we can't do clapping on the webinar, but thank you very much for that.
I'll clap you guys.
Yeah. I just wanted to raise that if this has raised any concerns for you tonight, again, please talk to your friends and family, speak to your GP, go to the internet sites like Beyond Blue, or for young people, the Headspace, and ring Lifeline on 131114. And those numbers will be on our website tomorrow, with the webinar on there as well. Just a couple of other things. Our next meeting is on August the 12th at 7 p.m. and it is on a very different topic, on trade. It's called Let's Do a Deal, Australia's International Trade Tensions, Challenges and the Future. On that webinar, we have Professor Lisa Toohey, Professor of Law at Newcastle University and an international expert on trade. Dr. Adam Triggs, the Director of Research at the Asian Bureau of Economic Research at ANU. And Dr. Bin Lee, who's a lecturer in law at Newcastle Uni, with a particular interest in the bilateral relationship between Australia and China. So again, very topical issues for August. In September, we are focusing on a little bit of a lighter topic, but just as important, on the contribution of the arts to Australia and our communities, which thank goodness has been a lifesaver for so many people over the past 6 months or so. We're looking at their intrinsic value on how they enrich our lives, but also on their economic value and their contribution to health and wellbeing in society. In October, we've got Michael Ondaatje returning to discuss the state of play in US politics. If anyone's had the privilege of listening to Michael at our previous events, he's the most requested speaker that we've had and has been there many times, really tracking the US elections and midterms. He will be talking about having critical discussion and insight into what is going on in the US at the moment, whatever that is at the moment. So they're the next 3 months planned out. Thank you again, panellists. We're very privileged to have you. And to everyone else, good night and stay safe. And particularly Pat, hope things start to improve in Victoria.
Indeed.
Yeah, thanks very much, Robin.
Indeed. Thanks, everybody.
Thanks, Robin.
Take care.
Thanks,
Thanks,
guys.
Robin.
Bye, everybody.
Bye.